This pill right here, this is what tens of millions of people take every morning to protect their arteries. Their doctor checks their pressure, the number looks good, and they leave the appointment feeling like the job is done. Here is what the research actually shows. Controlling your blood pressure and stopping plaque from building inside your arterial wall are two completely different biological processes. Your medication does one of them. The studies I've been going through, published in the Journal of the American Heart Association, document this clearly. Antihypertensive drugs as a class have insufficient evidence to attenuate the progression of arterial calcification. The number is controlled, the process is ignored. I'm going to show you exactly what that means and what to ask your doctor at the next appointment. The question is this: does controlling your blood pressure also protect the inside of your arterial wall from plaque progression? The answer, and I need you to stay with me through this, is not what you think. Here's what I want you to hold on to for the entire length of this video. Controlling blood pressure and stopping plaque from building inside your arterial wall are two separate biological processes. They are not the same process. They are not linked the way the system has allowed you to assume they are. Your medication addresses one, and the research is now documenting clearly in peer-reviewed journals that it may not address the other. I'll show you the data, I'll show you the mechanism, and I'll tell you exactly what to ask your doctor at the next appointment. But first, I need to be honest about where this comes from for me. My father followed every recommendation. He took his medication every morning for 11 years. His pressure was managed at every appointment. His numbers were where they were supposed to be. And we still spent years in emergency rooms, multiple strokes, multiple hospitalizations, and I kept asking the same question nobody seemed to have time to answer. If everything was controlled, what was still progressing? That question is why I do this work, and it's why this particular research stopped me cold when I found it. Drop a comment right now with your age, just the number. I want to see who's watching, because what I'm about to show you depends entirely on how long the process we're talking about has been running. For decades, the public health framework around blood pressure was built on a straightforward idea: lower the pressure, lower the cardiovascular risk, and there's genuine truth in that. The SPRINT trial, one of the largest and most rigorous blood pressure studies ever conducted, showed that intensive pressure control reduces cardiovascular events and overall mortality in high-risk adults. That's real. That's established. I'm not here to argue against treatment. What I am here to argue is that we made an assumption somewhere along the way. The assumption was this: if the pressure is controlled, the arteries are protected. The mechanism we focused on, the one that blood pressure medication directly addresses, is hemodynamic. It's the force of blood against the vessel wall. Reduce the force, reduce the damage, and that's accurate as far as it goes. But plaque is not just a pressure problem. Plaque is a biological process. It involves cholesterol deposition, oxidative stress, inflammatory signaling, and calcium accumulation inside the arterial wall itself. And those processes respond to a different set of variables that most classes of hypertensive medication don't directly target. And let me say this carefully, because precision matters here. The evidence now documents exactly that distinction. Nobody told you that. When was the last time your doctor sat with you and explained the difference between what your blood pressure number represents and what's happening inside the wall of your artery right now? Not on the surface, not in the blood flow, inside the wall. That conversation, for most people on long-term antihypertensive therapy, has never happened. And that gap is exactly what I'm bringing you today. 3 years ago, I found a paper I've come back to more times than I can count. It was published in the Journal of the American Heart Association. It's a systematic review
which means the researchers didn't run a single study. They reviewed every randomized clinical trial they could find on one specific question: which interventions actually attenuate the progression of cardiovascular calcification? Write this down.
The answer, across antihypertensive drugs as a class, was insufficient evidence to affirm treatment benefit. I want to make sure I say this exactly right, because language matters here, and the distinction is important. The researchers found that antihypertensive agents, the medications taken by hundreds of millions of people specifically to protect their cardiovascular system, did not show, across the body of evidence they reviewed, sufficient evidence to conclude that these drugs reduce the progression of arterial calcification. Not that they make it worse, not that they're harmful. The finding was that they don't appear to stop it. And that finding, published in the Journal of the American Heart Association, is not a fringe result. It's a systematic review of randomized clinical trials. It's the highest tier of evidence available. Now, I keep coming back to this one, not because it's the only paper on this, because of the way it's written. The authors didn't bury the conclusion. They stated it plainly. And I remember sitting with that paper and thinking, how many people are walking around right now with a blood pressure number that looks fine, believing that the process we just described is being managed? I want to tell you about a man I'll call David. 67 years old, retired civil engineer. He'd been on blood pressure medication for 9 years. Every 6 months, he'd go in, get his numbers checked, hear that things were stable, and leave. He exercised 3 times a week, he watched his diet, he did what his doctor told him. He wasn't asking questions about his arteries because nobody had told him there were questions to ask. He found out differently, not because something went wrong. He found out because he asked for a specific test, one that his doctor hadn't ordered and hadn't suggested. And the result was a calcium score that was considerably higher than anyone had predicted for someone who had been managed for nearly a decade. His doctor's response was, "Your blood pressure has been well controlled. This is sometimes just the aging process." David's response was to come back with questions, better questions, about what the calcium score actually measured, what it predicted, and whether there was anything the current treatment plan was doing about the process that produced that number. Nobody had walked him through the distinction before. And that distinction between blood pressure control and arterial calcification is not a minor academic detail. It's the difference between treating a number and treating a process. Here is the mechanism, because you deserve to understand every step. Blood pressure medications work primarily by reducing the hemodynamic stress on vessel walls. Calcium channel blockers reduce the force of heart contractions and relax blood vessels. ACE inhibitors block a hormone cascade that raises pressure. Beta blockers slow the heart rate. Each class does something specific, and each class does it well enough to demonstrate reduction in cardiovascular events in clinical trials. But arterial calcification, the process of calcium depositing inside the plaque that builds within the arterial wall, is driven by a separate biology. It involves vascular smooth muscle cells that, under chronic inflammation and oxidative stress, begin to transform. They start behaving like bone-forming cells. They deposit calcium, the plaque hardens, the artery stiffens. And stiffness, independent of blood pressure, is a predictor of cardiovascular events, cognitive decline, and all-cause mortality in adults over 60. The two processes are not the same, and treating one does not guarantee you are treating the other. Does this match something you've experienced? A clean appointment, a good number, and still a nagging sense that something wasn't fully answered? Tell me in the comments. Before I get to the part that changes everything, the part that I believe every person on long-term antihypertensive therapy needs to know, I need to show you something about statins.
because there's a specific and documented paradox in this space that most conversations skip entirely. Statins. Statins have one of the strongest evidence bases in all of cardiovascular medicine. Their role in reducing cardiovascular events, heart attacks, strokes, cardiovascular death, is not disputed. If you are at appropriate risk, statins save lives. That is the established evidence, and I am not challenging it. But here is what the research also documents. Write this down.
Statins do not appear to stop the progression of coronary artery calcification. And in some studies, multiple independent studies, not a single outlier, statin therapy was associated with an acceleration in increase in coronary artery calcium scores. Not a slowing, an acceleration. This is, and I want to use the precise word, paradoxical. And it's been documented enough times in enough different populations that it now has a name in the literature, the statin calcification paradox. The proposed mechanism is not that statins are harmful. The mechanism is that statins stabilize existing soft plaque, the dangerous kind, the kind that ruptures and causes heart attacks, by promoting its calcification. In other words, statins may convert dangerous, rupture-prone plaque into harder, more stable, calcified plaque. That's actually a beneficial process for near-term cardiovascular risk. But it also means that a higher calcium score in a person who has been on statins for years may not be telling the same story it tells in a statin-naive person. And let me say this carefully, because this is the part that most conversations in this space completely skip. It means that if you're using your calcium score as a measure of whether your arterial health is improving under treatment, you need to know which treatment you're on, how long you've been on it, and what the score is actually measuring at this point in your history. Think of it this way. Imagine a construction site with unstable scaffolding. The scaffolding is dangerous. If it falls, it's catastrophic. Now imagine a crew comes in and stabilizes the scaffolding, reinforces it, makes it solid. That's a good outcome in the short term. The scaffolding no longer poses the same immediate threat. But the scaffolding is still there. The construction site is still there. And the reinforced scaffolding, now solid, now permanent, is what shows up on the CT scan as calcification. The dangerous process was addressed, but the underlying accumulation didn't disappear. It was managed in a different way than removed. This is, in my view, the most overlooked conversation in preventive cardiology right now. Not because the research is new, because the research exists, is documented, and almost never communicated to the person taking the medication. Now here is the finding that changes how I think about all of this, and it's more recent. The CCOT trial, published in JAMA in 2025, studied patients whose treatment was specifically guided by their coronary calcium scores, not just by blood pressure or cholesterol numbers. The researchers found that CAC score-guided treatment reduced plaque progression compared to standard care. What that means in plain terms is when the treatment plan is built around what's actually happening inside the arterial wall, not just what the blood pressure cuff says, the outcome is different. The test changes the decision, and most people in long-term treatment have never had the test. Have you ever had a coronary calcium score done? Not just a cholesterol panel, the score itself, the CT scan that measures what's actually deposited inside your arterial wall. Tell me yes or no in the comments. I think the number is going to be significant. Here's what I don't want you to do with this information. I don't want you to stop your medication. I don't want you to call your doctor and tell them they've been doing it wrong. That's not what the research supports, and it's not what I'm saying. What I am saying is this. There is a specific conversation you have not had, and you deserve to have it, and you now have enough context to ask for it, which is exactly the difference between a passive patient and an informed participant. 3 concrete steps with specific language
with numbers where I have them. 1. Ask for a coronary artery calcium score. This is a low-radiation CT scan that takes roughly 10 minutes and directly measures the amount of calcified plaque in your coronary arteries. The score is reported as an Agatston unit number. A score of 0, CAC equals 0, is the result that research consistently associates with the lowest near-term cardiovascular risk, sometimes used to de-escalate treatment in certain patient profiles. A score above 0, especially above 100, signals active disease that should change how your treatment plan is built. The CCOT trial showed that using this number to guide treatment changes the outcome. Ask your doctor, have I ever had a calcium score done? And if not, would it change how we're managing my care? 2. Ask about your LDL particle size and density. Standard cholesterol panels report total LDL, a number, but not all LDL particles are equal.
Small, dense LDL particles penetrate the arterial endothelium more easily than large, buoyant particles. They oxidize faster. They contribute more directly to plaque formation. A standard panel does not distinguish between them. An advanced lipid subfraction test does. The question to ask, are we looking at my LDL particle type or just the total number? 3. If you've been on statins for more than 3 years and your calcium score has been rising, ask your doctor to interpret that result in the context of statin therapy specifically. A rising calcium score on statins is not automatically the same signal as a rising score in someone who's never been on statins. The conversation should be nuanced. You now know enough to ask for that nuance. None of these require you to abandon your treatment. None require a new specialist. None require you to distrust your doctor. What they require is that you walk into the next appointment prepared to have a more complete conversation. You are not a passive recipient of medical decisions. You are an informed participant in your own health. And what we've discussed today, the distinction between blood pressure management and arterial wall biology, is the kind of information that changes the questions you ask, not the answers you accept. If you're walking away from this video with a different understanding than you had when you started, drop "informed" in the comments. That word tells me something reached you, and it tells the algorithm this conversation matters. Let me give you the 3 things to carry out of this video. 1. Controlling blood pressure and stopping plaque progression are 2 distinct biological processes. The medications most commonly prescribed for hypertension reduce cardiovascular events, but a systematic review in the Journal of the American Heart Association found insufficient evidence that antihypertensive drugs as a class attenuate the progression of arterial calcification. 2. Statins present a documented paradox. They reduce cardiovascular mortality, but multiple studies associate long-term statin use with accelerated coronary artery calcification, likely through plaque stabilization. A rising calcium score in a statin-treated patient is not the same clinical signal as a rising score in a statin-naive patient. 3. The CAUT-CAD trial, published in JAMA in 2025, demonstrated the treatment guided by coronary calcium scores reduces plaque progression compared to standard care. The test changes the decision, and most people in long-term treatment have never taken the test. There is someone in your life right now who has been on blood pressure medication for years, who leaves every appointment feeling like everything is fine, and who has never had a calcium score done. You know who it is. This video is for them. Share it. That's the whole reason this work exists. And if this is the kind of evidence-based research you want to keep seeing, the subscribe button is right there. I don't post every day. When I post, it matters. Of the 3 steps I just gave you, asking for a calcium score, asking about LDL particle size, or asking your doctor to interpret your score in the context of your treatment, which one are you taking to your next appointment? Tell me in the comments. I'll be reading. One thing I haven't told you yet.
There is a specific blood test that can tell you whether the inflammatory and oxidative process driving plaque formation is currently active inside your arteries, and it's not on most standard panels. It's not CRP. It's a marker that tracks the specific biology we've been describing today. In a future video, I'll walk you through exactly what to ask for, what the result means, and how to use it in conversation with your doctor. Make sure the bell notification is on. That video is coming. Take the 3 steps I outlined to your next appointment, not instead of your doctor, alongside them. Bring the questions. Show them what you've been learning. Ask about your calcium score. Ask about your LDL particle type. Ask for a more complete picture of what's happening inside the wall, not just in the blood flow. I'm a researcher, not a clinician. I read the studies, I translate the evidence, and what you do with that translation is a conversation to have with a doctor who can examine you, review your history, and give you an answer that's specific to your body. That's the difference between information and care. You now have both. What you do next is up to you.